Hi, I'm Gary Chimes from Lake Washington Sports and Spine in Bellevue, Washington, and we're going to be taking a look at the lateral hip. So first thing for patient positioning, in this case I'm looking at his right lateral hip, so therefore I'm going to have him lie in a decubitus position on his left side, so his right side is exposed. As is the case whenever you're doing any portion of the hip examination, make sure that you have a conversation with the patient ahead of time about discretion and making sure that they know they're going to be exposed. I'm going to start with a linear probe, and I'm going to have this in a long axis view. So I'm going to go to the iliac spine on the left, which is proximal, to the right is distal, and that allows me to look at the entire length of the iliotibial band from its proximal origin. One of the reasons I really like to do this is, in addition to looking at the different layers of the gluteal musculature, it allows that when I get to the level of the greater trochanter, I have some sense of where that iliotibial band came from. Now what we're going to do is take a look at the gluteal musculature, and remember when you look at a myotendinous junction, you often get a bird's beak appearance. The reason for that is as a tendon inserts, inserting onto a curved surface. So this is going to have an appearance that's going to be very similar to that of the rotator cuff musculature. From here, I'm going to rotate into a transverse view, and that's going to give that classic peaked appearance. What we can see in this view, it looks quite smooth. This is actually a male who's still in the process of growing, so you can see some elements of the apophyseal growth plate still remaining because he hasn't finished growing yet. In this transverse view, if I come forward anteriorly, you're going to be looking at the gluteus minimus as it attaches onto the anterior tubercle. If I go posteriorly, I'm going to be looking at the gluteus medius as it attaches onto the lateral tubercle. There's actually 2 points of attachment. It will attach to the lateral tubercle, also it will attach to the supero-posterior tubercle. So you can see the overlying gluteus maximus muscle and the gluteus medius tendon underneath. Now, one of the things that is a great point of discussion is going to be, what about bursitis? What we find is that what is very common is, while you certainly can have bursa, we actually see what may be a little bursa just superficial to the gluteus medius tendon and underneath the gluteus maximus muscle. But oftentimes when you have patients complaining about tenderness in this area, it may in fact be what we call an enthesopathy, related to tenderness at the insertional point of the tendon onto the tuberosity or tubercle. One of the things that's going to be a distinction between a true bursopathy, where the fluid may be distended, is whether you can see fluid actually being distended or not. One of the key pearls is that when you're looking in these regions, make sure that you're using copious gel so that you're not accidentally pushing fluid out of the space. As a general rule of thumb, you're going to see fluid formation much more commonly if somebody has a traumatic injury. So if, for example, if they land on the hip, they may then fill up that bursa with fluid, as opposed to chronic overuse injuries, which are going to be more likely to be a chronic degradative enthesopathy. Now, one of the things that can be very tricky when you're looking at these evaluations is distinguishing between the tendons and the overlying iliotibial band, and that's where a dynamic evaluation can often be helpful. To help show you that, there's a little trick I want to show you, which is going to be using the upper leg as a fulcrum so that you can do a rotation. So what I really want to see right now is to be able to distinguish between the iliotibial band and the underlying tendons of the gluteus minimus and the gluteus medius. So first I just want to orient where we are. We're looking at a short axis view with anterior to the left and posterior to the right. So anterior, you're going to be seeing the gluteus minimus tendon with the attaching to the anterior tubercle. And then as I go posterior, we're going to see the lateral aspect, the lateral tubercle, and that's going to be where the gluteus medius attaches. But I want to get that triangular shaped view. And what I want to know is, am I looking at tendon or am I looking at iliotibial band? So I'm going to have my partner, Dr. Hyman, you may see his hand on screen. And what we're going to be doing is going to be rotating the hip into internal and external rotation. All right, so we have is a really nice view. We're using a gel standoff, so you can see some of that gel in the upper left corner. we have that classic triangular shape with anterior to the left and posterior to the right. And Dr. Hyman is going to be kind enough to rotate the hip, and we can see the iliotibial band sliding over the gluteal tendons. So as he brings that hip, can you bring that hip into maximum internal rotation? That exposes the lateral tubercle where the gluteus medius sits. And then as he lets the hip drop into internal rotation, you can then see that anterior tubercle. So right now, we're seeing the lateral tubercle. Let it go all the way into maximum external rotation. And there you can see the anterior tubercle, and that's where the gluteus minimus is attaching. Let's do that rotation one more time. We'll see the iliotibial band gliding over the greater trochanter. So therefore, you can think about what's your differential diagnosis. You can be looking for a dynamic pain related to the iliotibial band sliding over the greater trochanter. I can look for insertional enthesopathies of the gluteus minimus. I can go posterior to see the lateral tubercle. I can look for an insertional enthesopathy of the gluteus medius, and then I can just make sure that I'm not pushing down too hard so that I'm not missing the fluid associated with a true bursopathy.